Good evening, everyone. Is this microphone working well? Okay. Well, good evening again. We are very excited today. Thank you all of you for coming, and we're excited to have today Dr. Adnan Hyder as our speaker. I'm going to start by sharing some information about the Institute for Early Childhood Wellbeing, and then, of course, introduce our speaker of tonight. So let me tell you, well, I'm Dina Castro, and I'm the director of the Institute for Early Childhood Wellbeing. I'm going to share with you information. I'm here with my colleague, Dr. Ruth Paris. You can see her here. She is the Associate Director for Research of the Institute. I want to share with you also who else is part of the Institute. We are a very interdisciplinary group. As you can see, the Faculty Governing Board is formed by colleagues from across BU. And you see, and here I'm sharing about our fellows. We have a lot I have to mention also, and be grateful to Dr. David Chart, who was a previous dean, who had the vision and supporting the creation of this institute. And we hope he continue associated with us. So what is this institute for? Why is that we created the Institute for Early Childhood Wellbeing? So the mission is, this is a research institute. So our mission is to conduct research that can transform early childhood ecosystems to support young children's health, education, development, and well-being overall. So we are committed in particular to address, to propose innovative solutions to address the consequences of social inequities and structural factors that are affecting the well-being of young children in particular, all of the adversities that are present in our societies, unfortunately. And well, what can I tell you about the current times? So society is going in a direction that is really been harmful for everyone, but in particular for our youngest, the children throughout. So this is kind of in general. So how we do this? The Institute fosters collaborations to conduct research that is convergent. So it comes from the conversation, the dialogue across disciplines. Scholars are conducting research from different disciplines, so that we believe also that the solutions that we propose to address young children's well-being need to be holistic, need to be grounded in the work with the community, engage the communities. So the problems that we addressed and research that we supported our institute come from that work with the community. So this is important, very important for us. We do not go to the community to address the questions we create in our labs, and then go to gather information using the community as a place to generate data. Is that we have the community leaders and community participants as part of our research teams. And this is, you all understand this when I talked about later about the research that we support. So what are our priorities? The first one is to have our institute become a national and international leader in early childhood well-being research. So in how to do it, again, building these collaborations across disciplines and thinking about convergent approaches to conduct research. And convergent approaches that are grounded in our work with the communities, right? We hope to increase external funding that has been challenging for everyone in academia lately, we know, but that's one of our goals, and we're trying to do it. And of course, as a consequence of that, disseminate the work that we do, disseminate research findings at different levels to educate and also educate and produce the new generation. So we have right now postdoctoral fellows, doctoral, master level, and undergraduate students engaged in the research that the Institute supports. Right now, we offer internships, for example, for graduate students, and we are supporting, as I said, doctoral students, undergraduates, and postdocs who are involved in the different studies that the Institute conducts. So types of activities, just to go a little faster. We have three main types of activities. One is this one that you are, for which you are joined us today, the annual keynote lecture on early childhood well-being. And every year, as you can see, we have been addressing different topics that affect young children in early care, education, workforce development, mental health, for example. And today we will be discussing children's health. In addition to that, we have the monthly, what we call research in progress meetings. These are opportunities for researchers who are conducting, as I said, in progress, who are working on a study to share it with colleagues and get feedback from colleagues from different disciplines. And sometimes in the process of conducting research, we have questions, we find challenges, or in situations in which we need we could benefit from the feedback from other colleagues. So this is a space for that to happen. And in the spring semester, usually we also have another opportunity for networking opportunity for researchers conducting research related to young children's well-being as well. So we want to provide a space for researchers interested in the well-being of young children to find each other. And we have some examples of that has happened already in the previous years, and the years that the Institute exists, in which colleagues have found in these events and then discuss how they could collaborate or come out with an idea that requires the contribution of different perspectives. Okay, so I think here I have several examples of the research. I just want to mention that the research that is conducted and supported by the Institute for Early Childhood Wellbeing is local, national, and international in scope. So we support studies, or studies that are concerned about what's happening with young children Head Start program in Boston, but we are also supporting programs for parents in Louisiana, or working with colleagues in Colorado and other states. So, and also, of course, just move to our colleagues also are in different parts of the world conducting research, in particular supporting communities in the global South. This is, Asia, Africa, and Latin America. So I think that's all I wanted to share. It was a few more minutes about the Institute that give you a good idea of who we are and what's the type of work that we do. And now let me go to the important part of this event, which is introducing our keynote lecturer, Dr. Adam Hyder. Dr. Hyder is the Dean and Robert A. Knox Professor at Boston University School of Public Health. We are also with this activity welcoming him to Boston University. Dr. Hyder, you are welcome. We are so excited and fortunate at Boston University to have you. Dr. Hyder is internationally recognized as one of the world's foremost scholars in health systems and policy. With more than 25 years of experience advancing global health in low and middle-income countries across Africa, Asia, Latin America, and the Middle East, his pioneering research has shaped the understanding of systems design and constraints, biomedical ethics, safety, and injury prevention in developing context of scarcity. So please join me in welcoming Dr. Hyder. Thank you.
Thank you very much. Good evening, everyone. First of all, a huge thanks to Professor Castro and members of the Institute for inviting me. This is going to be my first talk at BU. So this is an incredible opportunity for me to engage with the BU community and really talk a little bit about my professional interests. I want to recognize all of you spending your evening here today. I know there are many busy people in the room. I want to recognize Dean Bishop of the Wheelock School. Thank you for your support and encouragement, and also for supporting the Institute, and Dean Dannerline for always being a great supporter of our public health community here as well. So I'm going to talk a little bit about my thoughts on emerging and new challenges to child health from a global perspective. Essentially, what I've done is divide the talk into really three sections. I'm going to share with you a little bit of data. I'm going to try and explain it as best as I can, but happy to take questions afterwards. I'm then going to talk about some of the challenges that I feel are being thrown at child health and development right now, and then flip that around and talk about ways of addressing those challenges and potential pathways for the future. And then we can later on have an engaged discussion and dialogue about that. But let me clarify a few things. First, my talk is a very high-level strategic talk. So I'm not talking about a particular disease, although I will be using some of my favorite diseases to demonstrate examples. I'm heavily influenced by my global work. I've worked in about 90 countries around the world. And so I will generalize and I'll use certain assumptions, but of course we all know there are exceptions to every rule, and I'm happy to engage in those. And being a public health researcher, I'm heavily biased towards health as opposed to development and well-being, although I've tried to expand my thinking in the past decade. So those of you in the other fields, bear with me a little bit as I pursue this dialogue. Also, Professor Castro, with tremendous respect, I've expanded the definition from early child to all children. And so we'll talk a little bit all the way up to 18 or so in this talk. My disclosures are there, and if anybody wants further information, please be in touch, and I'd be happy to talk about funding sources. But nothing that I'm presenting today has any correlation with a particular funding project as such. Okay, shall we begin? First, part one, let's talk about data. I'm going to share the latest outputs from the Global Burden of Disease database that were actually announced on October 14th in the World Health Summit in Berlin. This is the Global Burden of Disease database maintained by the Institute for Health Metrics and Evaluation at the University of Washington. This is the most comprehensive global database of over 347 causes of death and disability that I know exist in the world. So I'm going to share a few things with you and make a few points. First, these are the global death rates for people under the age of 19 around the world. First important thing to realize is that people under the age of 19 die in all parts of the world. The second point is they don't die at equal rates. There is an inequality in these rates. Keep this picture in your mind because I'm going to come back to this a little bit later on in my presentation. If you look at time trends, on the left side are bars demonstrating death rates about 30 years ago, and on the right side are death rates demonstrating the most recent data from 2023. One thing to note says, good news, death rates have gone down of the top 10 causes, the absolute numbers. And then, however, over 30 years, new conditions have come to fore. Mental health conditions, substance abuse, violence, all things that we didn't necessarily see in global databases have started emerging. And now I'm going to test your eyesight a little bit. But look at this as years of life lost from mortality. So this is a mortality picture, and the age groups are represented as you go from left to right. And these are the under 19 age categories, and the colors demonstrate the types of disease conditions. Generally speaking, the reds are the more infectious, the greens are the more violence and injuries and mental health, and the blues and purples are all many of the chronic conditions. If you look at within this bar that I've identified, as you move from the youngest children to the older children, you see that colors change. Therefore, this means that even with respect to mortality, the causes and the consequences of mortality differ by age group. And that's very important for us to remember as we continue in this pathway. But then you might ask, well, this is mortality. What about morbidity? What about ill health? Let me show you the chart for ill health. For those of you who don't know disability adjusted life year or DALYs, just consider this morbidity adjustment of mortality, right? Morbidity and disability adjustment of mortality. Again, look at the coloring over there. This, in fact, it even becomes more pronounced. So the impact on years actually living with ill health is very, very significant over time as you move from the youngest children to the older children, and mental health, substance abuse disorders, chronic conditions come to the fore. This is important for us to remember as I continue in this conversation and this change. Let's look at the top 20 causes of death by income category, since this is a global perspective. If you look, and again, the color coding in general is reds are infectious diseases, the greens are violence and injuries, and the blues are all chronic conditions or non-communicable diseases. You see in high-income countries, the leading causes are green and blue, as opposed to low-income countries that are all red. This means that the assumption that all children are dying of similar causes is obviously not true. And therefore, it depends on where you work. And that's important for us to remember. Now, this is deaths. If we look at morbidity, very similar picture again. The high-income countries, a lot of blue and green. The low-income countries, a lot of red. Even when they're alive, these young people are being afflicted by different types of disease conditions. And therefore, I think you might then disaggregate by age. And so here I present to you 4 different charts. And here again, you see that the youngest age categories overall in the world are heavily infectious disease oriented. But as you go to the older children, they are more and more being afflicted by conditions of injuries, violence, substance abuse, and chronic conditions. Sometimes we don't really get that global picture because it doesn't cover our own country. So let's do a couple of slides on our country as well, the US. Here are the top 10 leading causes of death. Again, over a 30-year time period, once again, you see that the rates have come down, but maybe not as much as globally. Maybe not as much as globally. And then new conditions appear, including things like, as you see here, substance abuse and disorders that are afflicting children of different ages. If you disaggregate this by age groups, again, the younger age groups, there's a mixed pattern of green and blues. In the older age groups, heavily influenced by violence and transport injuries. This was not true 30 years ago. This was not true 30 years ago in this country as well. And that's really important for us to remember. When we think about this as a static picture, it's actually a very dynamic and evolving picture. And so some of the key lessons is that, yes, the world has done well by getting gains in mortality reduction. And by millions of children, we are saving kids. But what this means is that there are still millions of children dying below the age of 19. In fact, about 5 million or so below the age of 5. The time that these kids spend in good health, unfortunately, has reduced over time. And therefore, different types of conditions are afflicting these children. And a lot of them are now things that maybe 30 years ago we weren't aware of. Even 20 years ago, we weren't paying attention to. And I'll come back to that issue in a few minutes. And fundamental to this picture, and a message that I'm beginning this conversation with, is there is an inequality in the burden of health, disability, mortality, and morbidity across the world. This inequality should fundamentally be unacceptable to us. And we'll talk a little bit more about why this should be unacceptable and what we as a community can do about it. Are we okay with the data for now? Excellent. Okay, great. I'm now going to move in and transition into really the second part of my presentation, where I want to talk a little bit about the challenges that I see. These challenges that I'm talking about now build on the data that I've already shared with you. But I'm going to expound on them a little bit. Let me begin by saying that today, if you look at this country, in fact, some of the leading causes of death are things that we could not have imagined. Gun violence, for children. Firearms. We could not have said that that would be a leading cause of child mortality in this country, including for young children under the age of 5. And in fact, since COVID, there's been a spike in that. If you look at time trends over time of mortality rates per 100,000 children, as demonstrated in this chart, you see there's heart disease, there's chronic conditions as well, but right on the top are motor vehicle crashes and gun violence. And particularly in the last few years, there's been an uptick. This is of great concern to those of us who are concerned about social and public health policy. And so my first challenge to you all is that actually we have a normative challenge. We have a normative challenge because people don't believe. They question this. This could not be true. This is not what I learned in medical school or health school or nursing school or whichever school you went to. There has to be an understanding of the evidence here. There has to be an understanding that this picture of child health burden is changing and we have to own it. Otherwise, we will not begin to address it. So that's my first challenge for our community. Outside this country, and I use Bangladesh as an example of a low to middle income country, very good advances have been made in the control of infectious diseases, diarrhea, for example, and respiratory conditions, and the mortality rates have really gone down. However, with those coming down, what hasn't changed are the mortality rates from other conditions. And here, it is incredible that between the ages of 1 and 5, over 50% of children in Bangladesh die from drowning, something that we hadn't really thought of, we hadn't talked about. This means that there's a challenge out there for us to look at. If you look at time spent here in this country, if you look at the years lived with disability, that is morbidity, across the panel, and I'll just use one side of the bar chart, you see the colors here in blue. This is all conditions that are afflicted, as you can see, with substance abuse, mental disorders, and chronic conditions. This is a lot of time being spent in these states of ill health. In fact, if you convert this rather than by disease to risk factors, and the next slide will show you the same two charts, but divided by risk factors, you will note again that there's a lot of blue in there. And what this blue is pointing out are to things like diet, drug use, alcohol, substance abuse. That's a lot of time and percentage of years being spent affected by those conditions. Now, the problem is that our systems were not designed for these conditions. Our systems were highly biomedically oriented. If you look at our medical system, our healthcare system, and in many cases, and I know far less, and my colleagues on the panel, I'm sure will talk about this, even our social welfare and disability systems were often disease specific because they took their cues from the medical system. And now we are flipping this around. This means that we have to question our systems. We have to begin to think, do we have the systems in place to address these challenges? So I am saying that our challenge is to reconsider the fundamental design of our systems and how can we enhance and improve them. So that's my second challenge to our community. We are all involved in some way or the other with evidence and research. This is a fantastic paper that just came out looking at the intensity of pediatric clinical trials across countries. You will note the heavy clinical trial load in the US and in places like China. This is good because more clinical trials are being done. Let's pause on that for 1 second and say, if this is where the clinical trial picture is done, let's bring back that picture that I showed you. And that talked about where the mortality rates are highest in the world. There is a mismatch here. This means that research investments and funding that are promoting the discovery of new knowledge is misaligned with the highest burden rates that exist at the global level, right? So this brings me to the third challenge, which is a research challenge. And this research challenge has been described in many different ways, but it is incredibly important to do research where it is locally relevant, to produce and develop solutions that are important for the local environment. And academic centers like Boston University have to become leaders in promoting that and actually conducting that. And I know many of you are in fact leaders in that space. The other thing that happens is that when an intervention is discovered, countries take a lot of time to introduce it. This is a great slide that I've used for many years, demonstrating how many years it took after the proving of a vaccine or a medical therapy to even start the introduction of that in a particular country. 10, 15, 20 years. And you wonder why. Well, it brings us to the next challenge, which I call the policy challenge, which is that our policymaking processes, and some of you may be expert in that department, why is it that they have such a lag between the generation of evidence and the adoption of that for our country, our region, our state? This is critically important. And in this case, when we talk of child health, it is incredibly important to also include maternal health and women's health, because in many cases, they are joined. And then when we introduce something as a policy, what happens? Do the people who need it actually receive those interventions? Can you imagine? It's been over 50 years that some of these interventions, and I'm sure Jack will be amused that all of them come from my field of injury prevention, have been around. Do you think every child who needs a car seat in this world has a car seat? No. No. This is a catastrophic failure of our health systems, right? In fact, if you look at this country, if you look at simple causes like road traffic injuries here, there's a huge differential between urban and rural areas right here in our country. You wonder why. If you compare the US with OECD, the highly developed countries, there's a huge differential between why our children are dying at a higher mortality rate than others, even though we have interventions available. And so that is what I call the implementation challenge. The implementation challenge is even when we know what works, it doesn't get to the people who need it. And that's a failure of our health system, our social system, our education system, all our systems. This is huge. This is really, really important for us to consider. So I've taken you through 5 challenges that I like to identify. I'm sure you can all do your own analysis and come up with additional challenges that I haven't spoken about. But I think these are foundational, from the evidence all the way to getting to the last child that needs the intervention. That is very, very important from an equity perspective, right? But of course, today is not just about identifying challenges, but also thinking about what can we do about it. And I look forward to our panel building on flipping some of these things around. And so I'm going to start addressing these challenges. And I'll give you 5 possible pathways of addressing them. And in this case, what I'll do is I'm going to define the pathway and then give you an example or a perspective after that. So dear colleagues, first, I think it's time to redefine child health. That's a big one, but I'm going to challenge us all to do that. I think we have to expand our focus of what child health and development actually means. I think we have to enhance our information and our knowledge systems. And we have to refocus our energies into going well beyond, certainly from a traditional child health perspective, well beyond mortality and morbidity, into things that maybe many of you have studied, which is why this interdisciplinary forum is so incredibly important. In fact, the World Health Organization has something called the triple billion target. The triple billion target, and I believe in that, is that 1 billion people should be under universal health coverage. We need to protect people, another 1 billion from health emergencies, and 1 billion more people enjoying better health and well-being. I don't know when we'll get there, but that's 3 billion. That's nearly half the world's population. That's a goal for us. Second pathway. I believe that we need to create new models of care. What we mean by care, both on the medical side, prevention side, but also lifelong care, because that child needs to be a healthier adult. You need to save that child from the injuries and the traumas and the violence, or that child would pick up risk factors for lifelong chronic diseases. And that becomes incredibly important. And then integration of people who have recovered back into normal lives. This reintegration into whatever the normal life is incredibly important for us. You know, increasingly, as I look at this data for our country, and I look at how this information here, for example, look at that coloring. In the first 19 years of life, you've got every single disease spectrum affecting our morbidity pattern. This is going to be very, very important for us to address. This is going to be critical. Another pathway that I believe is important is the pathway that I think is close to all of us. Instead of talking about child health research or child development research, how about research for child health and well-being? Whatever it takes, right? All methods, all disciplines coming together, whether it's engineering, whether it's social sciences, because we have to design systems and societies that will promote child health and well-being. And that's all what is called all-of-system approach, which is incredibly important. And to do that, our methodologies have to improve. We are often focused on our primary outcomes and one single outcome. We have to begin to think of complexity studies. And when we think of complexity studies, it is incredibly important that we think of multiple outcomes. And in some ways, we have to question our social mission. What is our social mission as a university, as a hospital, as an educational institution, for example? Because in some ways, our organizations have to reform as well. And in fact, there is a higher movement thinking about what the social accountability of universities is. How will society hold us accountable? And we're going to talk a little bit more over the coming years in that. There's a new Lancet Commission being launched in this direction as well. My fourth pathway for change is what I call enhanced decision analysis. I think we just have to become better at convincing others with our information knowledge. How can we become more relevant to a wide variety of stakeholders? How can we speak different languages to convey our messaging? What types of additional analyses do we need to do, whether it's economic modeling or social science modeling? And it is incredibly important to demonstrate that because society, for example, from a public health viewpoint, very recently is developing, unfortunately, an increasing mistrust towards institutions, particularly health and medical institutions. Maybe it's garnered by some forces, but we still have to take some responsibility for that. It is important for us to address it. And for child health and development, the stakeholders are immense. You have governmental, official, public sector, you have non-governmental organizations, educational institutions, you have economic institutions, and communities. And the communities really are the main foundations. But our angle has to change. Our perspective has to change. And I thought of one way of showing you what it means to look with a different perspective. Again, going to my field of study, which if you haven't guessed, has been injury prevention for a lot of my life. On the left-hand side is one way to look at a road, right? And we look at risks of a child or an adult crossing. But if I showed you this picture, your reaction will change. Your reaction will change. You will understand the acuity and the intensity of the risks involved. It's from an old textbook, about 15 years old. But I thought it was revealing. I just used this picture as an example of how we have to open our eyes and open our lenses. Which then brings me to my final pathway. For those of you interested in institution building, we have to improve our governance. And that has to change both locally, nationally, and at the global level. We have to understand this responsibility. We have to figure out, in this case, as a university, how can we address this issue? In other cases, as a city, how does the city of Boston address its child health, as a city, as a state, and so on? Because the world did come around to talk about what was called Sustainable Development Goals. But by the way, they are ending in 2030. So what happens in 2030? Well, right now, at least one country is not happy to engage globally, but looking at all the other countries, what happens? What is the post-2030 plan going to be like? Can we bring 194 member states of the United Nations to the same table? That is a pathway, but a possible pathway that we should begin to think about now, 5 years ahead, so that we can build us. So, once again, I introduced 5 important challenges from my perspective to global child health. I've shared with you 5 different ideas of how to move this forward. I hope they make sense to you. If not, let's have a robust debate and discussion. But let me close by talking about something that is incredibly important to me throughout this discourse, which is when we think about this, it is incredibly important to not forget our value systems. And our value systems are based on, and go back to one of the first things I said, inequality in child ill health, in child death, in child lack of well-being is unacceptable to us. because it's unfair. We can do something about it. We know what works, and yet children are being left unattended. This is a mission for social justice. And that mission for social justice should underpin all of our work, because this value system is the moral compass by which we determine where to invest our energy and our resources. And hopefully, if we can convince the powers to be, the funders, the investors, the policymakers, they will also follow suit. So I hope you'll join me in this pursuit of rethinking child health. Thank you very much, and I really appreciate the opportunity.
Thank you very much, Dr. Hyder. You have left us with a lot to think about. And now we will invite our panelists, our colleagues, Dr. No. Yep. Yes. Yes, please come forward. And I will leave you with Dr. Lindsey Locks, who will be the moderator for the panel discussion. Yes.
I'd like to invite to the stage. We're very excited to have. Oh. Okay. Dr. Aisha Yousafzai. She's a professor of child development and health at the Department of Global Health at the Harvard T.H. Chan School. Come on up and join us. Eleonora Villegas-Reimers, who's a clinical professor and chair of the Department of Teaching and Learning at BU Wheelock. And are the other panelists online today? We did check. Okay, just check. Okay, and we also have Alice Tenjiwe Kabwe, and Dr. And she's a champion for inclusive childhoods and community-led solutions. She's the co-founder and African projects lead of the Universal Baby Project. And then we also have Beztabe Butron-Riveros, who's a pediatrician and public health specialist, and a former regional health advisor for the World Health Organization. And they are joining us online. So thank you both for joining us. Okay, so we can start. It's been not a great year for child health. I think that 2025 has really reminded us how vulnerable children are in this world. We're seeing vaccine preventable outbreaks. We're seeing persistent childhood malnutrition and displacement. So from your perspective, where have our systems fallen short? And what do we need to be doing differently to better protect children's health and development over the coming decades? And so why don't we start with our panelists in person first? So, yeah, Aisha.
Thank you. Thank you. So as we've seen in the talk, the challenges are enormous. So I want to try my best to attempt to inject a dose of optimism based on my reflections of the progress that we have made in the last 25 years. So if I think back to 2000, the early 2000s, the enormous challenge that the child health community faced was, how do we reduce child mortality? At that point in time, there were just over 9 million young children dying from preventable illnesses in the first 5 years of life. And today that number now stands at less than 5 million. So there's a way to go. But the ingredients that I think helped that progress was, first of all, political engagement and political will, whether that was through the Millennium Development Goals at the global level and then transitioning into the Sustainable Development Goals, but also political will and political action at the local and national levels. Secondly, we had a robust evidence about interventions, about solutions that we knew worked. And really what the child health community galvanized was momentum to, how do we take that learning through implementation at scale? So where does that leave us today? Our challenge isn't just child survival. It's also how do we support young children to develop? How do we support young children to thrive? And that's particularly important because the challenge is enormous. We have 45% of the under fives in the majority of the world not meeting their learning development milestones, not meeting their social emotional development milestones in those early years. And yet we have some of those same ingredients available to us. We have nearly half of low and middle income countries that have either a national framework in early childhood development or a multi-sectoral policy. So we have some political engagement. We have evidence that's fairly robust in knowing of the types of interventions that work, whether that's mental health support among caregivers, whether that's parenting support, whether that is early childhood care and education. So the question then becomes, as you've asked, are our systems ready? Are they really fit for purpose? And I would say, at least from a health systems perspective, there are 3 areas where we're clearly not paying attention. The first is our workforce. The workforce in primary health care and community health care have been trained in child survival solutions, right? So you give a supplement, you give a vaccine. What we need for them to be trained in is behavioral change. How do you counsel families? How do you build on families' strengths? How do you solve problems? If a mother is having difficulty breastfeeding, you can't just keep saying breastfeed exclusively for 6 months. How do you change that narrative? And also, if many of these interventions are tested with community health workers, how do we ensure that task shifting doesn't become task dumping? We can't rely on a volunteer workforce. They need to be appropriately reimbursed for their services and valued in terms of professional development investments. We also need to ensure accountability. So I would say that means not just measuring, are we giving immunization? Are we measuring child growth progress? But do we have indicators to track child development in our health systems? And then finally, we can't keep stacking vertical program after vertical program. We need to ensure that what we introduce as new interventions in our existing platforms complement the existing child survival interventions. So how do we do that in a way that's feasible and effective? How do we bundle parenting with nutrition? So it's not enough to have evidence. It's not enough to have policy. We need to build the readiness within our systems.
Dr.
Should I go, or do
Villegas-Reimers?
you want to?
No, you can.
I'm going to build on what you just said, because I think that the key issue that we are not naming by name is education. And educate not only the education. Yes, thank you. It's not only the education of the young child, it's the education of the parents, it's the education of people who are going to go into politics, it's the people who are going to be leading our organizations, it's leadership. It's all level of education that we really need to pay attention to. And together with education, we need to pay attention to ethics. I think that we have forgotten for many, many, many years the importance of the ethics of our work. Working with children, working with family, working with teachers, working with the health systems in general, and looking at systems. It's not enough. We cannot only look at systems, but we cannot only look at individuals. We really need to cross levels. I am always fascinated, and I'm so glad that you mentioned the Sustainable Development Goals. I'm fascinated by the fact that when I am in the United States, in my classes, and I mentioned the Sustainable Development Goals, most people have no idea what I'm talking about, except if they come from another country. And when I am in another country or an international organizations, and you don't mention the Sustainable Development Goals by name, they correct you and say, well, do you know that we have this Sustainable Development Goals? And it's like, yeah, absolutely, I know that. I know Goal 4 really well. So it is one of those things that we really need to think about. But what I'm thinking about in terms of education, and I really mean that, we have forgotten the importance of parenting education. We have forgotten the importance of teacher education. We have forgotten that our societies, and I include every society in the world, truly, it's in many, many ways dependent on what we do to prepare the people who will be teaching the young generations. There is a lot that needs to happen at the education level to educate people about health, about healthy behaviors, about social emotional learning, about all these things that we're talking about. And yes, respect that there are some issues that are medical issues that should be in the hands of the medical professions, but there are a lot of the causes that doctors show us that are absolutely psychological, social emotional, that we all need to, in a way, take responsibility for that. And that for me is when the ethics comes in of, and what are we doing? What is our responsibility? When do we stop to say, is the system, is the government, is the policy? And when do we begin to ask ourselves, and what am I doing for that? And yes, I am one. But how can I influence a system? How can I influence institutions? How can I really create an environment so that if we all begin by that basic question of what is my role, what is the role of what we need to do, and where am I in all of those systems playing some sense of I am going to focus on preparing teachers as I do. Other people are focusing on preparing doctors. Other people are focusing on preparing politicians. We need everybody. We cannot have in a way, the argument of, oh, I'm only going to do that because that's the most important. We really need to look at everybody. Looking at and thinking about the area of the world that I know best, which is Latin America, I invite all of us to think about the fact that most of the maps that you show, that you talk about low-income communities or low-income countries and high-income countries, there is a very, very, very strong correlation between income and level of education. So the big question is it low-income countries or is low levels of education that are happening in those countries? And then the other piece is that when we go into the global south and we bring education ideas, how many times do we really take the time to learn about what is it that they already know? And what am I bringing that makes absolutely no sense for them? And how, and I'm going to introduce my third idea, and then with that I finish because I do want to hear the other people, is, and what role does it play to think about the new technologies that we have? It was unthinkable, at least in countries like the countries that I work in Latin America, to think about that we would educate children outside of school systems. And the pandemic hit, and all of a sudden we are educating children through WhatsApp. And we have lesson plans in WhatsApp, and they are working. And the students are following what we're doing in WhatsApp. So yes, they don't have access to the highest level of computers or anything, but they have a phone and they have WhatsApp, and they can communicate that way. I remember commenting and actually sending lesson plans for teachers to use in WhatsApp during the pandemic. So we have to also think about that we have the technology now that we didn't have even 30 years ago that we can use. How are we using? And again, not only in the function of health, that's the ultimate goal, and health and well-being, but in the interest of education and educating the general population. So that then when we hear things like this vaccine causes autism and we have the evidence, we have the knowledge and the way to communicate. This is something that we all need to learn about. And then in a way, show that with information and education, we probably can begin to improve the life outcomes for lots and lots and lots of children and families of all ages. So, thank you.
Okay, Dr. Butron-Riveros.
Yes, I'm here. Can you hear me well?
Yes.
Yes. Yeah. Well, hello, everybody. Thank you very much for this invitation. I want to thank Dina for inviting me, for giving me this opportunity. And thank you, Dr. Hyder, for such a comprehensive and thought-provoking presentation. I just want to focus my comments on two areas. I believe we can do better if we present child health in a different way. I agree with Dr. Hyder that we need to rethink how we communicate and how we think about and understand child health. We have sufficient evidence saying the importance of relationship for children. We know that child health and well-being is relational. We know that the health and the well-being of children depends very much, is very much dependent on the well-being and health of the parents and other caregivers that are important in the life of children. But the reality is that we keep talking about children as if they were alone or in isolation. We don't make explicit reference to those caregivers and the importance the caregivers have in the life of children. And I think we can do better. We know the parents and not only model behaviors and emotional response, they can build resilience. And we have the knowledge how effective parenting interventions are for mental health of parents, for child development, for violence prevention, and many other outcomes. But these times are very hard times for parents. They don't have the time, the resources, the support to provide to their children what they consider are the best things for them. So I think we need to make more explicit this relationship between children and adults, children and parents, children and mothers and fathers. We don't do enough work in trying to engage fathers in caregiving. In Latin America, most of the countries have a policy and a strategy to promote child development. And these are policies that are multisectorial: health, education, social development, even labor, and other ministries are involved. We still have the implementation challenge mentioned by Dr. Hyder. There is a gap between what is written in the paper, in that policy, in that strategy, and what is happening in reality. But the good news is that the discussions that is taking place right now is growing and growing. I can see it in my country. I'm from Peru, and I can see it in Colombia. I can see it in Brazil, in Chile, certainly, where people are, again, making a lot of advocacy activities to raise the importance of relationships for child health and well-being, the importance of parents, the importance of other caregivers. In our region, more and more children are going to daycare centers, are going to preschool, which means that children are being taken, the caregivers are not parents, are not family members. So working for children health and well-being also means taking care of these adults, making sure they have the work conditions in place, making sure that they have the support they need. So in summary, I would say that in these times, in these current times, talking about child health and well-being means about putting children at the center of every decision of the government. It's not only about health or education or social protection or any other ministry in isolation. Child health and well-being means involving all sectors, involving academia, involving families, involving communities. And I want to finalize touching on this last point. We know that families and children are diverse in so many ways, but our policies and the strategies tend to be homogeneous. At the time we write those policies and think about those strategies, we forget about the diversity of children and families, and diversity in so many ways. And that is the reason why we have still this equity challenge mentioned by Dr. Hyder. One, I would like to suggest and propose that one way we can start working to decrease to address our attention to diversity is by making a reality the participation of families and children, making sure that we don't only provide opportunities to hear their voice, the diversity, their lived experiences, but also to seriously take into account what they say, value their comments, value their experience. It's as important as the evidence, as the science that we have. I think we all recognize that we still have a lot of way to go on that area. I would say I will continue comment on different things later as the meeting goes on. Thank you.
Great, thank you so much. Dr. Tenjiwe Kabwe.
Thank you. I hope you can hear me okay. Yeah, I've been really nervous about this, but I think perhaps I am among like-minded professionals and in the right room. So yes, my name is Alice. I'm not a doctor. I'm a granddaughter. I am a daughter. I am a mother. I have two boys who are 10 and 8, and they're a big part of what drive the work that I do. And my vision, as a parent, or I don't know, but one of the things I've always really wanted for my children is that they grow up in environments that are inclusive, where differences and variability is normalized, where, their first meaningful interaction with a wheelchair user, someone with a developmental delay, someone who has a mental illness, is not on their first job, that they can experience this variability and this beautiful variability of humanity from the beginning as early as possible. And it's this, the beauty of childhood, as I'm sure we all know, it's like children naturally figure things out. They find a way to include, and they find a way to play with each other. And so I appreciate this invitation to reimagine systems and reimagine partnerships. And for me, it's thinking about how can we take this kind of instinct that children have to be inclusive and to play, and to reimagine our systems from that perspective, and have these environments where variability and different systems are all integrated into one. We know already that systems that are designed intentionally for those on the margins become systems that are stronger for all. And how can we take those same understandings in our contexts? What if, for example, disability inclusion was really mainstreamed into routine services, where developmental concerns are identified early during everyday visits, where psychosocial emotional supports are integrated into under 5 care and not only during or after a crisis? What if our healthcare workers, early educators, community caregivers, and caregivers themselves were really equipped with skills to support children across these topics? And what if that was like our baseline expectation, that services, programs for young children were holistic, were inclusive, where developmental support, disability inclusive practices, mental health, responsive caregiving, that these were actually embedded in? And what if that was the gold standard? And we have examples already of these holistic programs that can work. And the question is how to next move into designing them. When it comes to partnerships, I imagine my reimagination of partnerships, I think, is partnerships that are brave enough to explore difficult questions, where we can examine our own biases, ask ourselves, like, how does my background, my gender, my race, my culture, my training, my education, how does this show up in my design? How does this show up? And what lens does this bring into the community that I'm working with? Partnerships that acknowledge power, history, colonization, existing structural inequalities, and how they show up in our relationships as well. And ultimately also as well, it's like reimagining partnerships that root themselves deeply in Indigenous and community knowledge, in other ways of knowing and appreciating and honoring these other ways. Can we learn about and really value child rearing traditions and histories, and the variability of caregiving across diverse cultures, and such a beautiful variability as it is. Can we honor these? Can we highlight this and, generate a rich knowledge base of Indigenous caregiving knowledge that sits alongside equally scientific understanding? And what if our partnerships could hold science and local knowledge equally together? So those are my kind of questions and hope for the future when I think about reimagining systems.
I do have a second question, but I want to make sure we have time for questions from the audience. So I want to open it up and see if anybody has something they'd like to ask. Otherwise, I have lots of questions. But
You go first. Hey, my name is Omnia. I'm first year student at BUSPH, so very much looking forward to this whole lecture. My question is, how does one navigate the cultural barriers that come to this? Because it's really like, I love the idea of educating everyone, starting with the caretakers, parents, older siblings, even your doctors that you see day to day. It's really nice to say it in the US perspective, right? Because a lot of cultural assimilation. But you go around the world. I can use my country as an example, Sudan. Like teachers are not like talking about primary care and go get your vaccinations. We're just trying to get the math done. Like go to your homework, get a good grade. It's really hard to implement that. Well, that's my goal to implement it like long term, which is why I'm doing what I'm doing. But it's really like, how does one navigate that cultural barriers?
Yeah.
does anyone have it?
So I'd really appreciate if Betsy and Alice were to chime in on this, because I think they may have a better perspective. But culture is a word that is often said, but very difficult to understand. So if you're talking about the culture of a whole society, it is very different than talking about culture of a system. So for example, in my conversations, I talk about what is the culture existing in a public health system? Is that an inclusive culture? Is that an inviting culture? But you could be talking about the society's culture, something that Alice just said. How can we take a situation, take a system and ensure that what was considered, quote unquote, abnormal is now normalized, so that there is an entire shift in culture in that consideration? I think it's possible, and I'll tell you why. Because 25 years ago, we were smoking inside rooms. Now we walk out 12 feet away. We actually don't appreciate the intensity of that cultural change. The fights that restaurants and bar owners had to try and prevent that, the amazingly odd ways the tobacco industry is still fighting us against that. It's a small example, but it's an example to say that you can have a fundamental shift if we all agree on a value. It's really tough to find values that we all agree on. Those will be few and far between, but I think there might be some. And so that's my opening answer to that, but would happy to hear other colleagues, particularly from the Global South.
It's working. Actually, building on what you just said, think about culture is a set of, and it's a set, and it's a set, it's a set of values and it's a set of beliefs. So when you have a culture, what you are really is, what is the shared value that we have? And that can be at the institution, it can be at any level. Changing the value and changing that shared value so that you are in a way changing the culture is what is hard. But the culture usually, the quote unquote easier ones are practices. What you just said, how do I teach a teacher to do this? And you teach them by showing them the evidence and showing them the practice and everything. The harder ones, from a cultural perspective and in interactions and in trying to change a value, is the things that are invisible. what do we communicate without words? How do we communicate by whether we keep eye contact or not? What does it mean, eye contact in this country and in another country? In other countries, eye contact can be sort of challenging. I'm challenging you by keeping in your eye. As I'm talking with you, I need to look down because you are more authoritarian than I am, or you have a higher level than I am. All those little tiny things, those are harder to change. But the kinds of things that we're talking about here, those are not that hard. It's 25 years or more with a change of smoking, and it hasn't changed in all countries, by the way. But it's easier because it's something that is visible, and it's something that you have data for. And I think that that's where I said the education comes into place. I'm not talking about education necessarily schooling. I'm talking about educating people about facts and how facts can then influence practices. And in the middle of all that, yes, values play a role. But the most important thing is, what facts can I show that are clear, evident, and simple to try to convince people that this is a better behavior? Acknowledging that it may not be something that is valued in their country. Let me give you one tiny example, and it has to do with health. The country where I come from, we have a significant population of indigenous people who have not been in contact with what they call the Western world, which is those of us who live in the city, in the cities in the same country. And they have significant health issues that have been solved quickly with medical professions. But they do not accept that because that is not true. We treat that with this plant or this way or that way. And what the government did at some point to us to talk about the Western world illnesses and your world illnesses. So for your world illnesses, you treat them. But for the Western world illnesses, you know that we have brought to you, let us treat it. And so they accepted vaccines that way. They accepted that when they have a fever, they go to the doctor. But when they have any spirit that came into them and it's making them have bad thoughts, they go into their own shaman. And in working hand in hand and really looking at how can we learn from one another, how can we use the strength of both sides of the culture, and how do we really educate both? Because both needed to be educated. It's not only the doctors knew about, the sort of the Western medicine, they didn't know about all the other stuff. How do you educate both can make a significant difference, because then it's also the valuing of, I value you as a human being with experience. I know what you're going through. This is not my expertise, but I'm going to help you with the side that is my expertise. And that kind of respectful thing also talks about the value of accepting cross-cultural differences, multicultural differences, all those kinds of things. So that would be one tiny step. And there are many things like that can happen.
Yeah, Alice, chime in, I think.
Thank you. I'll be brief. I think what comes for me is something about meeting people where they're at, and if where they're at and what their priority is school, let's go to school. Let's let's listen. Let's co-create something new and something different. I think there's always a place of connection and alignment. You know, one of the things I love to do in my work, if I'm working in a new community, it's just starting off like, how do you care about young children? What does that look like for you? What's important? What's important for you as a community? Because what I think is important may be very different than what they think is important. But we can find some common ground in that question. You know, I mean, we want our children to survive and thrive, like everybody does. How it looks can be different, but we can start from that place and then start to explore solutions together.
Dr. Butron, did you want to weigh in or?
Oh, well, I agree completely with Alice. I think when we face barriers, the first thing I would suggest to do is just listen. Try to understand what is the source of those reactions, those opinions, those behaviors. And then you will realize, as Ali said, that there are some commonalities, and that could be your starting point to work together. Sometimes, and I'm a medical doctor, so I understand that my colleagues are not so flexible sometimes. We are the toughest to change, to listen. But I think that is one of the things that we should incorporate in our work, is try to listen where these ideas, these rejection or behaviors are coming from. And I'm assured that we will be surprised to see how easily we can find common ground and start our conversation from there. Thank you.
Others from the audience? Question?
Hi, I'm Stephanie. I'm on faculty at the School of Public Health at BU. I guess my question is more sort of policy oriented. I'm curious, the work I do and have done for a long time has been about early childhood, but particularly thinking about shifting policy with evidence and trying to get policymakers to understand that taking care of kids is taking care of families. So it's very easy, I think, in policy to focus on the child, separated, as multiple people have said, from their family. So I'm just curious what that looks like in an international setting. It feels like on the international level, that's a more accepted concept than here in the US. And just curious for thoughts about framing that works and doesn't work, and moving policymakers' understanding of the ways that we need to support families in order to support children.
So I think that's really important, and maybe I'd like to draw on two examples, one directly from my own work in Pakistan, and then another from work that I've been engaged with in Kenya. So when I started my work in Pakistan, which was on how do we integrate parenting support through community health platforms and primary health cares, we needed permission to trial the evidence with the community health workers, the lady health workers in the region. And at that time, we went to the federal government to ask permission. And I didn't get past slide 1 before they said, this has nothing to do with health. This is an education question. We're not going to give you permission. It took a year of really advocating, really figuring out what is the question that we can answer that will be helpful to persuade the health sector that this should be trialed, and then we can produce evidence that's useful for decision making. And so the first thing I would say is that from that experience, that it's a long conversation. From that point, it took a year before we got permission, and it's taken, that was in 2008. But it's really only this year where this evidence from this trial and a substantial growth in trials in the country has led to really where we now have a national policy framework through the Ministry of Planning and Coordination. I forget the exact name of the ministry. So I think it's just, I think we sometimes as researchers, we know that we can produce good evidence. We just need to, I think that sometimes we need to also ensure that the way we're framing it and the questions we're asking are also useful for policymakers in the context. But the second example, I think, is pertinent both in the US and globally, and it's around childcare. So I work with an organization called Kidogo in Kenya, which is a social entrepreneurship where they train mamapreneurs to establish businesses for childcare that provides women on low-income communities somewhere safe. And they've been really successful in making the economic case and the gender equity case for governments to support, or the Nairobi district government and the national government to be engaged in how they can support childcare. And I think often in early childhood work, we have been very successful in saying that there are long-term returns on investments. And that argument is important. You invest early, you build a strong foundation, you'll have healthier adults, more productive adults. But it's politically expedient to also think about what are the shorter term arguments, and actually more women in the labor market, in the labor force, being able to invest in their own in resources for their own children because they can work is a pretty good argument for universal childcare if it's done well, if it's done with quality and invested in appropriately. So I think sometimes we have to think about what are the arguments that actually matter politically and within a political cycle.
Can I add to that as well, please?
Yes.
Yes.
What comes up for me is I agree with all of those points, and yeah, it does take time for sure, and there's an aspect as well of relationship building, and I think with governments, their governments operate so in siloed. They're siloed. There's education, there's health, there's social protection, there's social welfare. Sometimes it's sports, child health kind of. Sports kind of get mixed in there as well, and so this idea of that Aisha shared already about like understanding what the priority is, understanding what for those sectors, because while sectors can come together, and ECD is a beautiful place that does bring sectors together at the table. Ultimately, the budget is going to education, or that budget is going to health, and there becomes, well, where does this child fall and at what time? And so being able to speak to the needs of that sector specifically can be helpful.
Yes. May I?
Of course.
Oh. Yes.
Yes, Betsy, go for it.
Yes. I'm thinking about my experience working closely with my colleagues in Chile, in Colombia, and in Brazil, when they started designing the programs to promote child development. I think one of the common activities for all these three countries, very different countries, but one of the common thing is that they use evidence from the beginning. But the way they present evidence was very interesting, because it's not so much about talking about how rigorous the research was or the methodology or all of that. That is important, but it depends on who your audience is. But when you are trying to convince different stakeholders in having this policy to promote early childhood development, you will have an audience coming from different ministries, from different institutions. So when presenting the evidence, it's important that you explicitly present the benefits for everybody, not only for health, not only for education, but for everybody, and do it in a strong way, in a simple way, easy to understand way, and not only once, but in a continuous way. All these countries were talking about the evidence in different forums, in different spaces, with different audience, all the time, from national to subnational to local level. That was the initial efforts. And then the second element is that the high level commitment. The president of Colombia at that time, the president of Chile, one of the ministers, the Minister of Social Development in Brazil, those were the champions of those policies at the beginnings. They were convinced, not only, it was not only rhetoric, not only talking about the importance of children and child development. It was really part of their constant follow-up with ministries. It was part of their speech. Every time they talk about some different social issue, they were talking about children. They were talking about how important child development was to reduce equity, to increase productivity, to develop the country, et cetera, et cetera, et cetera. So having that high level of authority, really committed, was a second element, a very important element. And the third one was that at the local level, there was an effort to involve providers from different services, not only health services, but also educators, those working as social workers, etc., those working in municipalities, and etc. So there was a very intense effort at the beginning to put everybody on the same page, everybody understanding what is it that we are trying to do. And the commitment came from the highest level of authority all the way down to the local level. And that, of course, changes over time, depending on where you are in your policy development process. But I think those were the key ingredients to make those countries successful in having very strong commitment, very strong policies that are already happening. Chile already has more than 10 years with this strategy, and it's survived different changes in governments with different political views. The same thing with Colombia and Brazil and other countries. So I think I think sometimes it's difficult, but maybe some of the elements of these countries could help you in your work on promoting early childhood development. Thank you.
Yeah, well, thank you very much for the question. I want to agree with everything that my colleagues have said. And I want to tell you that if you do everything that they said, it may still not work. Because, and we must have some controversy before this conversation ends. Otherwise, it's too polite. I haven't found a blueprint for fixing the research to policy pathway. There are anecdotes in every disease in every country. And so that everything they've said is correct. But you flip the policymaker, you flip the ministry, you flip the time frame, you flip the community agent, and it'll fail. So Jeremy Schiffman, if you haven't read his papers, you must, because he is one of the people who've brought together what is called the policy window, the policy frameworks, and the policy points that all come together in weird ways to bring it all together. And he's seen this in neonatal health, he sees it in child health, he's most recently published in humanitarian health and so on. There are a dozen other policy frameworks specific to the US, but also to low and middle income countries. Side note, include a few that I've published, which you may want to read at the end. But I think it is incredibly important to test. You've got to know your context, you've got to know your time frame, and you've got to have a mix of all of this, the champion, the evidence base, the conversation, the short term, the long term. I don't know what's going to work. I'm very sorry to tell you, but you're going to have to be ready with the menu of options and be it for the long term and figure it out. So this is the one question that actually I'm not sure we have a good answer for, but thank you for asking it.
Can I respond to you? One of the things that I have found over the years is that it's not only you change the policy, you change the senator or the politician or the whoever. It's also that we have to pay attention also how even the same argument can be used for or against. And we have to be the ones who change if we are going to continue the advocacy that you're describing. So that then I know in my head, and people laugh when I say that, but when I'm advocating for early childhood education, I'm always thinking, okay, am I going to use the brain development thing? Am I going to use the financial economic thing that the mothers need to be in work? Am I going to, and I have like 5 different things because it depends on who you're talking to that you need a different argument so that it makes sense. So it is a good thing that we don't have yet found the one answer.
Take over. Okay. Wow. That's also the little bit of controversy just got all settled out, that we all agree that we need everything. I'm Ruth Paris. I'm the Associate Director for Research of the Institute for Early Childhood Wellbeing, and I'm here just to close us out. And I really do mean that wow, because I feel like I was taking so many different notes from so many different perspectives. So I want to appreciate Dr. Hyder to start us off and to offer what is a really big perspective that I'm going to have to just read and think about a lot more. And to all of our panelists who I think gave us so much more than we could have even imagined from all of the different perspectives that you brought. I'm trying to look up at the screen here. I know you're realizing you're not seeing me looking up. No, maybe you are. Okay. So thank you so much. I think that, as you know, that Dr. Castro presented, our institute is about early childhood well-being. And I appreciate, Dr. Hyder, that you said health, but I hope that tonight you really get some more language for the development and well-being and all the different things that we're talking about. And again, you know, our little piece of the how early childhood, and I know you know that, but how early childhood matters so much because everything is built on those early years. And I just want to encourage you to keep coming to our events. We're here. We are going to, some of us are going to be doing, there's a research on TAP that's happening in February that's sponsored by the Provost's office, and it is focused on immigrant children, and it will be children, you know, a bigger age, but specifically people at BU who are doing research on immigration and childhood. So that's scheduled for February. I don't think we have a date yet, but there's a number of us who are going to be, February 26th. Thank you, Dina. And we are around continuing to do our events, and I hope that we see you again. So thank you again to our panelists. Thank you, Dr. Hyder, so much. Thank you to you all.